Hello and welcome. My name is Lori Green, Program Director of Gulf Coast Ultrasound, and I'll be the moderator of today's session entitled Doppler Evaluation of the Fetal Heart. Gulf Coast Ultrasound is accredited by the ACCME to provide AMA PRA Category 1 credits. As such, we are required to disclose any relevant commercial relationships we have to our audience. We have not received any commercial support to present this program to you this afternoon. And with that, I'd like to introduce our speaker, Jill Beathon. Jill is a registered sonographer from Fergus Falls, Minnesota. She has worked in the sonography profession since 1980, and she's registered in breast, abdomen, OBGYN, vascular, adult echo, and fetal echo. She's currently the ultrasound services manager at Sanford Health Systems in Fargo, North Dakota. Jill lectures extensively throughout the United States on fetal echo and other ultrasound-related topics, and we've had the privilege of working with her for several years, and she is an awesome speaker, so I know you're going to enjoy this presentation. Thanks very much, Jill.
Thanks, Lori. I'm going to be talking today on why and how to use color and spectral Doppler in the fetal heart. So we're going to start out with the basics, and first of all, I have no relevant financial relationships. I'm going to start out with the basics and just go a little bit over flow. How does flow go through the fetal heart? This we particularly need to know when we're working with color and Doppler because they're going to tell us direction. And when we've got structures that are very, very tiny and we're trying to decide which way flow is going in a particular vessel to distinguish which vessel that is, or if there's an anomaly, we really need to know exactly what the normal direction of that flow is by color, both by color and spectral Doppler. So we're going to start with a very basic anatomy. Here we have the superior vena cava and the inferior vena cava, and we're going to show a red blood cell. And we're going to watch the flow through the fetal heart. So the red blood cell starts, it comes in to the right atrium via the superior vena cava or the inferior vena cava. Then it has two pathways. One is to cross over between the atria by the fossa ovalis, or as this one chose to do, it can go through the right atrium, cross the tricuspid valve, which is the right-sided atrioventricular valve, and end up in the right ventricular outflow tract. Now the right ventricular outflow tract is still in the ventricle. So now we're still in the ventricle, in the RVOT, and we're going to leave the right ventricle, and we're crossing the pulmonary valve. The blood comes up, the main pulmonary, and would love to go to the lungs because that's where it needs to go after birth. However, the lungs are pretty high pressure now. So the blood doesn't want to flow there quite so readily. It wants to go to a lower pressure area. So there's a little tube at the end of the main pulmonary that dumps into the aorta. That's a very, very important structure in the fetus. That's a shunt that can get the blood away from going to the lungs. We don't want it to go to the lungs yet. The lungs aren't ready for it. So we need an escape hatch to get this blood away from the lungs. So we have the ductus arteriosus, a little bit of a tube at the end of the pulmonary, connects to the aorta and dumps the blood away. So now we have a way for this blood to get out of there. Here's our red blood cell. We're continuing. We're joining with the blood from the aorta and continuing on back to get reoxygenated in the placenta. So here's the little red blood cell that did go through the left pulmonary artery, got into the left lung, and now it's coming back to the heart via one of the pulmonary veins. So this one, the only choice it has is to go into the left atrium. It can't cross back to the right atrium because the flow goes from right to left at that level normally. So it has to cross into the left atrium, into the left ventricle. Then it's going to end up in the left ventricular outflow tract, which is still in the left ventricle, and now it's going to leave the left ventricle. It leaves the left ventricle, goes across the aortic valve, up the aortic arch, might go to the head, might go to one of the blood vessels in the head, and then it mixes with the blood from the ductus arteriosus, comes down the aorta again, and again back to get reoxygenated. So think of all of those structures and all the directions it's going in this teeny little space about the size of a quarter at 20 weeks. And it's beating. So it's difficult. So we need every tool we have to try and figure out what's happening in this little heart. And we're going to talk about how color and Doppler is going to help with that. Other than anatomy, the next thing we have to know in the fetal heart is, why does it keep going? What happens? What's the mechanism of flow? Well, it's the contractibility of the heart. It's how that left ventricle contracts and pushes the blood out. So we have to understand cardiac electrophysiology. This is very brief about that. The brain sends electrical impulses to the sinoatrial node, which is located in the right atrium. This node then sends out signals through the atria, through the muscle of the atria, and as it travels through the atria, these pathways, it contracts the muscle fibers. It's an electrical kind of stimulation, and the muscle fibers contract. When they contract, the atria get smaller. As they get smaller, they push blood across. So the atria then become a mechanism from the electrical stimulation to cross over into the ventricles. Then approximately 120 milliseconds later, that signal arrives at the atrioventricular node. And that's kind of in the crux of the heart, right in the middle of the heart there. That then sends out signals through the ventricular walls. And the ventricular walls, then the muscle fibers contract. And those walls then, the chambers, get smaller. As they get smaller, they're pushing the blood out. So that's the mechanism, how we get ventricular systole, the squeezing part, and ventricular diastole, the relaxation part. So now, how does that look when we are doing a Doppler of that? This next slide is only here so you don't have to take notes on the next 5, okay? So you can sit and listen to this. What I'm showing here is the heart in different stages of the cardiac cycle. And I'm showing what the Doppler signal would look like with a pulsed wave Doppler through the heart, apex pointing up like all good fetuses do, with the sample volume kind of big in the left ventricle. This is what the Doppler signal would look like with the sample volume in this position in the left ventricle. So we're going to kind of move through that cycle and see what's happening. So here we're putting a Doppler in. We're just about to where the ventricles are going to contract. So that happens because the atrioventricular node fires. And it sends out these electrical impulse through the muscle fibers of the ventricle. So if you have a sample volume through your pulse Doppler, and you're in the left ventricle, and you're kind of big. So the reason we're doing this is because we want to see flow that's coming across the mitral valve, and we want to see flow leaving the ventricle. So if we leave kind of a big sample volume, and we angle up a little bit from our 4-chamber view, a little bit into our 5-chamber view, a little bit towards the fetal head, now we're going to simultaneously record the blood coming in and leaving. You can't take those numbers and do peak velocities from them because we're not in the right spot for that. We're just looking at timing of flow. So that's what this is going to tell us. The atrioventricular valve went off. Here muscle fibers started to contract. So our flow is going to be going away from us. Direction of flow is away from us in our Doppler signal here. And blood is going to be squeezed out the left ventricle and the right ventricle. As blood squeezes out the left ventricle, and we have a pulsed sample volume here, you're going to see the blood flow away. So this is the signal you're going to be getting at that time. All the while, the blood is flowing out the atria continue to fill. And they're filling via the inferior vena cava, the right atrium, the superior vena cava, and the coronary sinus, which drains the heart muscle. That blood also dumps into the right atrium. Also, the left atrium is filling via the pulmonary veins. So while the blood is leaving these ventricles, the atria are filling. Well, it can't go anywhere because as the blood is being squeezed in systole in the ventricles, it shuts the atrioventricular valves. So the blood is building up in the atria. So now we're past systole. Now the muscle fibers in the ventricle are now relaxed, and the ventricle is now dilated out again in ventricular diastole. Here's our pulsed sample volume again. We're still here in the left ventricle, but now the blood has ceased to flow away from us. So what's our Doppler going to look like? Here's it coming away from us, and now it stopped. Now we're kind of in the middle. Now the atria are filled and higher pressure because the ventricles have just dumped out. So the atrioventricular valves open up and just passively flow into the ventricle. So this is called ventricular diastole. And ventricular diastole has two parts. This first part is flow, this is what we're going to be recording. Here's our sample volume. We're recording early diastolic filling. So blood flows into the ventricles, and as that pressure starts to equalize, the blood stops flowing in. Right at that point, now we've kind of got a little equalization. Now, the sinoatrial node goes off. So now blood is, now the signal is going through the walls of the atria, contracting the atria, and the blood is flowing across the atrioventricular valves. So the valves open up again. Now the blood is being forced out of that atria because the atria is squeezing, and blood is again coming across the atrioventricular valves. So we have a two-part ventricular diastole while the ventricles are relaxing. Now we're at the end of that. Notice how our signal is in two parts. We call this the early diastolic filling. That's when the blood just from the atria just flowed in. And then we have the blood being forced in by the contraction of the atria. So we have an early diastolic filling phase and an atrial contraction phase. That's why when you put a sample volume here, you get this M shape. Excuse me. Now we're at the end of ventricular diastole. The atrioventricular valve fires again. Blood flows out of the ventricles as they contract and squeeze blood out. And we're back to the same, back to that full cycle. So that explains, with a sample volume in the left ventricle, why we would get this type of a Doppler signal from that spot. So this is what it looks like in ultrasound. Here we have our E and our A wave. E, we named this first point in diastole E for early filling of the ventricles. The A is the atrial contraction. This entire time the blood's coming across that valve towards us is ventricular diastole. The ventricles are relaxing. Here is ventricular systole. This is when the blood was flowing out. So with a sample volume in this location, that's the Doppler signal you're going to get. So we're going to leave that for a minute and go to color Doppler. What can color tell us? Why do we want to take our exam to the next level? Now we're doing for chamber view, we're looking at all of those elements, we're looking at outflows. We figured out how to do a sweep through the heart. We know your three-vessel view. And now we want to take it to another level. Why? Because of the information that we can add by using color and Doppler. Color is useful to assess the normal anatomy and physiology, valvular regurgitation or stenosis, shunting through a hole, and the orientation of Doppler to see where you want to put your Doppler to obtain the best waveform. So those are your good reasons to use color. First thing you want to do, we're going to get our apical or our 4-chamber view up, and you have to be able to identify every flow. You need to know what normal is. This is a frozen section, and it is in ventricular diastole. And how do I know that? Because the blood is flowing from the atria into the ventricle. So we have the red blood coming towards the transducer. Here's our color bar. Towards the transducer, flowing across the atrioventricular valves. Oops, here's my mouse. Not cooperating here. There we go. So let's look at that. That's the red. That's the flow towards us. And it's red. It's not white. It's not aliasing. So as we get towards the top velocity ranges of our color bar, it turns white. It's aliasing. But that's not happening. So we have a nice color scale set here. So we know the flow across both atrioventricular valves is about the same. Here we have a blue flow. So now we have flow going away from us. Well, why is that? We have to be able to identify everything. Well, here we're in ventricular diastole. The blood is coming up, hits that wall, and is kind of coming and starting to turn around the other way. So that describes what's happening in that spot. Here again is another little spot. Again, it's just kind of flow coming back the other way a little bit because it swirls a little bit in the ventricle. Here's how early can we see this. One of the things we wanted to see here is ventricular filling. Look at this 10-week heart. You can easily see, even at 10 weeks, by color, that we have both ventricles forming. Now I'm going to come back to this picture, and we wanted to identify all the flows in the 4-chamber view. We want to see where is everything going. If you can't identify the colors normally, we can't identify them abnormally. So let's look at them. Again, flow across in diastole. Then when the ventricle is squeezing in the left ventricle, you get a little bit of blue coming out. As that blue comes out, we're not up in a 5-chamber view, so we don't see it totally leaving, but that explains the blue at the opposite time of the red. So that's the red is ventricular diastole, the blood's flowing in, squeezing, and the blood's flowing out. So let's look at what other colors, because we have to identify everything. Right here, we have pulmonary veins. And if you watch during the cycle, we get a little bit of flow coming in. Okay, so that explains, there it is, that explains that flow. Let's come over into the right atrium. There seems to be a whole lot of flow in the right atrium. See all the red? Well, what happens in the right atrium? We have flow coming in from the inferior vena cava, from the superior vena cava, and from the coronary sinus. There's a lot of inflow there, and we're just picking that up. Then look behind each valve, right here and right here. Little bit of aliased flow. Well, what's that? As the ventricles contract, they're slamming those atrioventricular valves shut. When that happens, there's a little teeny bit of flow backwards. Not enough to be called regurgitation of the valves, but it's a little bit faster flow. That's why we get it at the top of our spectrum, and it turns white. Aliases a little bit, but that's normal. So you need to recognize that as normal flow, little teeny bits. So now we've kind of got it. That's the flows in that particular view. If you're in an OB setting, it can be hard to get your settings to where to be good in the heart. When you're in an OB setting and you're doing your scan and you're going along, and all of a sudden the baby turns and, oh, there's a great view. I want to turn on color. You have two choices. You can, one, manually manipulate your settings to get a good color flow, or you can go to your fetal echo setting. Well, going to your fetal echo setting is great. You can get that done and go to that, and hopefully your applications person has set up your machine so that those settings are all perfect. However, what we want you to know, how do you set them up from the OB setting? So you've got all your settings perfect. You don't want to lose those settings, but now you want to go to the heart. Where is your color scale set? If you're in an OB setting, you're going to have a low color scale, a low pulse repetition frequency rate, because you want to see venous and arterial flow. You want to see lower flows. When you put your color on and doing a routine OB, you want to see venous flow in the vein. If you put color over the cord, umbilical cord, free floating out in the amniotic fluid, you want to see slow flow in the vein, and you want to see fast flow in the arteries. So that's how your scale is set. When you take that same color and all of a sudden the heart turns and you want to look at it, and now you want to look at the 4-chamber heart, the flows are faster. We don't want to see venous flow anymore. You've all done it. You turn on color and you're in an OB setting and it's just flash everywhere. What do? There's a pretty easy 2-step method to get you pretty close. First thing you do is you're in an OB setting and you want to do the heart. And you put it over the heart and you've just got it everywhere. You need to increase the color scale. Go to your knob, increase your color scale. Get it to a higher pulse repetition frequency, higher number, so you're blocking out the lower flows. So there's your first step. Just take your scale, turn it up, until you see flow across the atrioventricular valves without aliasing. Then take your overall power or your overall color gain and turn it down a little bit. It'll still be kind of bright. It'll still be kind of overflowing your walls. So take your power or your gain and just turn that down, and you'll end up most of the time with a very adequate setting. Now there's all kinds of other settings and machines these days that can prioritize color in certain ways, or can use filters. However, if you're in an OB setting, you have to do it yourself. That's a great 2-step way to get there. So what all do we want to evaluate? Here we're in color. What do we want to see? One of the things that you want to focus on is the filling of the ventricles. We know that the right ventricle can be 20% bigger than the left ventricle. And we see that from looking width to width. So as I look across here, this is the right ventricle, and here's the left ventricle, and I see flow in. As I am looking at the width of this flow, neither one is aliasing, so they're both going about the same speed, which is great, so I know I'm set right. And there's a little bit wider flow in the right than in the left. That's normal. The right ventricle can be a little bit larger than the left ventricle. That's completely legal. Look at this one. Here is a 4-chamber view, and looking at it closely, you can see that this ventricle is too small, and we have a little endocardial fibroelastosis here. So this is a hypoplastic left heart. So you're really busy, you're in the room, and you've got kids running all over the place, and a lot of distractions. You want to make sure you are looking at this fetal heart, and what you see is going to slap you across the face. This is a 4-chamber view. If this patient was harder to visualize than this, or if there was a whole lot of distractions, you could potentially count 1, 2, 3, 4. Now we have 4 chambers. Once you put on color, however, this is a huge slap in the face. You couldn't possibly say, you couldn't miss this. Here's color. We have it flowing into the right ventricle and none into the left ventricle. So color in the 4-chamber view, put it on. Now you're going to see the flow and the ventricular filling into your ventricles. So that's one of the things you want to look at when you're applying color in a fetal heart. Take a look at this one. Now this is much trickier. Here's our flow into the right side, and here's our flow into the left ventricle. That's going to take a real experienced person to say this flow is too small compared to the right. We're expecting the right to be more than the left, but this is too much. So, you're not necessarily going to jump out and say that, but if you look at every heart you do and put color on, you're going to get better at doing it and recognize what your normal ventricular filling is. So let's put this one into motion. As we go to motion, we see the filling of the left ventricle. Yeah, but it's not great. I mean, it's a little small compared to the right. But in ventricular systole, you can see the flow out the aorta right there. So you know flow's coming in and flow's going out. Look right here, right behind the mitral valve, right there is a little bit of blue regurgitation flow coming back. We shouldn't have that. So how much is that? How are you going to quantify that? Well, by color, that can be really difficult because you can depend on your setting. If you have your scale set too high or your PRF set too high, you could not be seeing the extent of that flow. So you want to Doppler it. You want to know how long that regurgitant flow is lasting in that cardiac cycle. So now you got two minor things. You're doing this 4-chamber, left ventricle flow is a little small, and there's a little teeny regurgitation here. What are you going to do? Go up to the 3-vessel view. First thing, go up to your 3-vessel view. Here's a 3-vessel view, clearly abnormal. Put color on and it's even easier to see. Here you have the pulmonary, here you have the aorta and the superior vena cava. Clearly there is way more flow, much more volume going into that pulmonary artery than there is this aorta. So there's a clear diagnosis, and this was a 20-week case of aortic coarctation. Here's the aortic arch in this view, and right in this area, now no one's going to hang their hat on this. I know this was aortic coarctation because the child was just born. So we have a definitive diagnosis of that. In retrospect, you can look back at this, but you wouldn't have thought it. You wouldn't have thought about that without the little teeny bit of regurgitation and the little bit smaller left ventricle and the 3-vessel view showing it. So color was quite helpful in that case. Take a look at this one. Here's a 4-chamber view. Again, you got kids running around the room, you've got phone going off, your beeper's going off, all kinds of stuff. Looks like a pretty good 4-chamber heart. And we didn't have a lot of time to look at it. Let's throw on color. When we get to color, you see this very large tricuspid regurgitation. That slaps you in the face. The 2D alone didn't just slap you in the face on this case. But you're not going to miss this. This is aliasing, which means it's going really fast, which regurgitant jets tend to go really fast. And this is going to slap you in the face. Let's go back to that and take a look at that again. Now that you know you have a big regurgitant flow coming from that tricuspid valve, now you're going to think, why? Pressure's got to be high, backing up and giving us that regurgitation. Now you look closer and you realize this ventricle isn't contracting. The left ventricle, as it contracts, is getting smaller. The blood pool is getting smaller. The right ventricle, the wall, is not actually contracting. It's going back and forth. It's going along for the ride. So now when you go backwards and look, ooh, yeah, okay, this wasn't normal, but it didn't slap you in the face. As you watch a little closer again, you can see a little bit of bright echoes here, and that's an endocardial fibroelastosis. So this is a hypoplastic right heart. Why do we have the valvular regurgitation? Well, valvular regurgitation happens when there's an increased pressure or volume in the chamber upstream from the valve that's leaking, or when the valve itself is bad. So something was wrong, and it slapped you in the face when you saw that big regurgitation coming back. This is the same case, and it ended up, this was a pulmonary stenosis. So the valve wasn't totally atretic. There was still flow going across it, but there was a stenosis of it. So let's put on color. This is a still frame. Here was our left ventricle, and here was our right. The color is set to not alias. Actually, it's going to alias just a teeny little bit when you put it in motion across this aortic valve. Watch when we put it in motion. We expect the aortic valve and the pulmonary valve to be pretty close in velocities. Normally, the aortic valve is a little bit faster than the pulmonary valve. If you look at a chart, aortic velocities are a hair faster throughout the throughout the cycle. So here we go. We're going to put this in motion. Here's the aortic valve. Get a little bit of aliasing here, but as we sweep up into a 3-vessel view and in the right ventricular outflow, look at this huge amount of aliasing across here. That's because it's going too fast. That pulmonary valve is stenotic, and the flow has to go a lot faster. If you try and ignore the color in the 3-vessel view, the sizes really don't look that abnormal. Pulmonary and aorta. So the color in this case helps you tremendously. By throwing that color on, you can see the speed at which it was going and the direction. So we had both speed and direction problems with the color. Here's another case. As we look at this, I'm going to tell you it's a twin-to-twin transfusion syndrome, and this is the recipient twin. So this kid is volume overloaded. And you can see that the right ventricle contractility is really bad, but the left isn't necessarily great either. So when we go into color, look at behind the valves. The red is flow into the ventricles, and both valves, atrioventricular valves, are leaking. So this really helped us. And how bad is that volume overload? How bad is it? So you put on, you see bivalvular regurgitation on those atrioventricular valves, and that helps you assess the severity. This is a case that the only thing you can see here in this color is this little teeny little bit of tricuspid regurgitation. That was it. This was the only marker in this case that this was a trisomy 21. Nothing else. Everything else was normal in the case. So how are we going to say how much tricuspid regurgitation is that? Well, it doesn't look like a lot. It looks like just a little blue blip. When you go into Doppler, put a Doppler sample volume over right across the valve, a little bit on one side and a little bit on the other side, and you turn on your Doppler, you can see flow away from the transducer. Here's diastole, because we know flow is coming into the ventricle in diastole. Nothing should be going backwards. That's our regurgitation. If you look at the timing of this, it's the entire cycle. So it looked like a teeny little bit of regurgitation on color, but it's holosystolic on Doppler. It's the entire systole. So this is a little bit more than the color is suggesting. And again, it was a sign, and the only sign in this fetus, of trisomy 21. Talk a little bit about spectral Doppler. One of the reasons spectral Doppler is being used currently is to assess function. We want to assess ventricular function. How do the ventricles relax, and how do they contract? So we want to use our Doppler signals to tell us how that's happening. One of the most common ways, and very, very simple, is to do the E to the A ratio on the diastolic flow into the ventricles. Well, we already learned that that flow should look like an M. And the early phase, the E wave, is the first hump. The early phase is just blood flowing in. The next phase contributes more blood flow during fetal life, the A wave, and it's going to be a little bit taller. So these have a ratio, and they should be, there's constant numbers of what that ratio should be. So diastolic performance is assessed by measuring the forward velocities across the atrioventricular valve during diastole. The early passive filling produces the E wave, like we said before, whereas the active filling produces the A wave. The active filling contributes to the majority of diastolic filling in fetal life. And so normally your A wave is taller than your E wave. When diastolic ventricular filling predominantly relies on atrial systole, okay, when the atrial component is contributing more than the early phase, the magnitude of that A wave gets higher. So now we're expecting X amount of an E to A ratio, And with certain types of ventricular dysfunction, that ratio is going to be off. So when the early phase can't contribute as much, and why does that happen? If you've got a bad ventricle from perhaps IUGR. In IUGR, what do we have? Placental insufficiency. So you don't have as much oxygen, or not as good oxygen contact because of the placental insufficiency getting to that myometrium. It didn't learn how to be a ventricle as well as blood without the, well as the fetus without the placental insufficiency. So what happens? The ventricle is stiffer. It's not as compliant as a normal fetus. Because it's not as compliant, that when the blood flows, fills the atrium, flows across, the ventricle doesn't stretch out as much. So blood goes over, but not as much as you would have if you have a nice compliant ventricle. Then you get to the A wave, and now your atria didn't get all the blood out that it should have. So now the atria contracts, and you've got higher volume going across. So your E to A ratios are now going to be different. Here is a chart right off the website of Dr. DeVore, and he's talking about the E to A ratio. This is a measurement of the compliance of the stiffness of the ventricles as blood enters the chamber during diastole. In certain fetal conditions, like we talked about, the measurement may be altered. So here we have about a 31-week gestation. The E to A ratio is maybe 0.7. This is the normal where you would expect. In this particular fetus, it was lower. So a lower ratio is going to give the E wave lower than the A wave, lower than what's expected. Here's an article that came out talking about this, and it says, however, in late gestational age, so later in the gestation, the peak E to A ratios of both the left and the right ventricle in fetuses with IUGR and with diabetes were significantly smaller than in the controls. Here is a 20-week fetus. The E to A ratio on a chart is about 0.6. Later in the pregnancy, a normal ratio at about 38 weeks is about a 0.8. So we expect them to get closer later in gestation. Here's a chart, and if you look at these two charts, here's the mitral valve. We're starting out at about, 20 weeks, about maybe 0.6. So a little over half. You want to see that E wave a little over half of the A wave at 20 weeks. By the time we get to 38 weeks, we want to be a lot closer. And there's several ways. Here's the mitral valve, the tricuspid valve, and here's another way of looking at it. So we know what normals are. So why is it abnormal? Then we have to go figure out why is it abnormal. But this is going to tell us the diastolic function or the stiffness of the ventricles. When you do this, do you angle correct? If any time you need a peak velocity, a number that's going to tell you how fast is that blood moving across, you have to angle correct. So if you're looking at exact numbers, what's the height of the E, what's the height of the A? Yes, you have to angle correct. If you're looking at only a ratio, you can be off a little bit and it's not going to affect the ratio. So the answer is no. If you're only doing an E to A ratio, you don't need to angle correct. If you're also looking at the peak velocities at the same time, you do need to angle correct. In a fetal heart, you want to try and stay at about 30 degrees. You don't want it very much. This one is too far. So in this case, we're at almost a 45-degree angle correction here. So I could use, with fairly good certainty, the E to A ratio in this case, but I wouldn't use the peak velocities. And some charts give you peak velocities at certain ages. Here's 27 weeks plus or 7 days. Here's your peak velocity, what the E wave should be and the A wave. In that case, I'm off too much. I wouldn't want to use my peak velocities there, but I can use my E to A ratio. So depending on your chart, you have to be careful about that. So that's your diastolic function. It's a really good way to assess what the stiffness of that ventricle is. The other thing we want to look at is systolic function. We want to know not only how the elasticity is, how it's relaxing, but how is it functioning. So how is that squeezing out? Now we need peak velocities. Here's again right out of the website of Dr. DeVores. And he says the peak velocity, the measurement is, this measures the speed, okay, at which the blood is ejected from the ventricles. When the heart is not functioning properly, then the peak velocity will decrease. So we know at what gestational age that ventricle contracts and how fast that's shooting the blood out. We also know how long it takes. We can measure an acceleration time to see how long it took to get to that peak. So several different measurements can be used. This chart is just peak velocities. Here is an ascending aorta, and as you see, we're at 20 weeks here. We have about 70, about 60, 70. We look at a chart here, we know 20 weeks. Okay, that's certainly within the normal range. Here is a pulmonary artery at 30 weeks. Again, about 70. So the aorta was 70 at 20 weeks. It takes till about 30 weeks for the pulmonary. So we know that the flow from the ventricles is normally higher in the aorta, a little bit higher throughout the gestation than the pulmonary is. If you look at those two charts, put them on top of each other, the flow out in the aorta is going to be a little bit faster. And here's the absolute numbers for that. Here's an article that talked about it, and it's talking about the systolic function. And it says, while systolic ejection forces significantly increase with advancing gestational age, in normal fetuses, there's a significant decline in the systolic function of IUGR fetuses. So what are we going to use all these numbers for? We're still developing this. I mean, there's still a lot of research being done on why we use these numbers, but some of this is pretty absolute at this time. This is an excellent article I highly recommend if you want to do more reading. One of the things that you may be asked to do is what's called a mechanical PR interval. This is pretty common in maternal fetal medicine labs. A PR interval, again, we're going to go back to our cardiac electrophysiology, and we're going to define what a PR interval is. Here's our sinoatrial node. It fires. It sends electrical impulses through the atria, and they contract. It takes about 120 milliseconds to get to the atrioventricular valve. 150 is 3 standard deviations above the normal limit. So when you look at what a normal PR interval is in charts, sometimes you'll see the normal being 140 milliseconds, and sometimes you'll see 150 milliseconds. So it can be a little confusing in the literature. 140 milliseconds is 2 standard deviations above the normal limit. 150 is 3. That's why you get that literature being a little bit different. So if the pathways in the atria aren't as easy to traverse for the electrical signal as they should be, it will take longer to get there. If the time it takes for the impulse to travel between the SA node and the AV node is lengthened, it's termed heart block. So what a mechanical PR interval is doing is determining a degree of, or that there is a elongated time between the nodes, or heart block. On an EKG, the PR interval is the time it takes for the P wave to start to the time it takes to the R wave to start. It's the interval between the beginning of the P wave and the beginning of the R wave. Now that's on an EKG. Well, have you ever tried to put electrical pads on a fetus? Doesn't work. So we have to find a different way to measure that time. We want to know heart block. This will tell us heart block in someone you can put pads on, but on a fetus, how are we going to tell that? Well, going back to what we know is our normal flows across the ventricles, we can take a time from the beginning of atrial contraction. We know that's when atrial contraction happened because that's when the second time our blood flow went across. And we know when the ventricles contracted. And we can do a time, which is a mechanical PR interval, not what we consider a PR interval on EKG, but we call it a mechanical PR interval, because we're seeing the actual mechanical motion of the valves, and we can time that. Why do we want to do that? There was an article in Circulation magazine in 2008 that was titled Utility of Cardiac Monitoring in Fetuses at Risk for Congenital Heart Block, the PR interval and dexamethasone evaluation. This was the PRIDE study. And this is what they did in the study. 107 pregnant women with anti-SSA antibodies were enrolled. So these are people with some type of autoimmune problem, generally lupus. So your patients with lupus, most of those were the people who are enrolled in the study. They did a protocol on them, included fetal echograms performed weekly between 16 and 24 weeks, and every other week from 26 to 35 weeks. They used 150 milliseconds, a third standard deviation. Anything over 103rd were considered prolonged. The SSA, SSB antibodies tend to destroy those pathways, the electrical pathways getting to between the SA node and the AV node. So anything over 150, they considered first degree heart block. At that point, they would make a decision to administer dexamethasone, which in many cases then reversed that heart block. So that was what this study was about. Interestingly, in this study, the conclusion was that the PR interval was uncommon and it did not precede more advanced block. I thought that was a really interesting part of this, because you would assume that first degree heart block may lead to third degree heart block. But in the study, they said it really didn't. Once you have third degree heart block, it was not reversible, but first degree was. So they needed to know this PR interval, at what point we're getting to first degree heart block. There was a trend more towards congenital heart block in fetuses of women with previously affected offspring. We've had several in our lab lately that have had first baby had a heart block and has a pacemaker. So automatically you're bringing them in for their other children. And we watch them throughout the pregnancy and watch that PR interval. The conclusion on another article was prolongation of the PR interval was, oh, I'm sorry, that's the same article. Here we are going to show how you do it. This is the same way we did when we looked at how we were going to get the flow in diastole and in systole. So this is how you're going to take it. You want to be in a 4-chamber view, again a little bit high. As you come up towards the fetal head from a 4-chamber view, you're going to come into a 5-chamber view. And the reason is the left ventricle is oblong. So with a large sample volume, you can see flow coming in and going out simultaneously. That simultaneous recording will allow you to know when atrial contraction is and when a ventricular contraction is. So here's your PR interval. You take a measurement, time measure from here to here. In this case, we had 120 milliseconds. This was a normal PR interval. One more thing I want to mention, because more and more in MFM labs we're asked to be doing a T index. A T index is a measurement of a global myocardial performance index. So this is not only assessing diastolic function, it's also assessing systolic function. So it's a global myocardial index. We're going to take this the same way in the left ventricle that we do as a PR interval. This was an article in Obstetrics and Ultrasound Obstetrics and Gynecology magazine, and the article was entitled Fetal Cardiac Function Assessed by Doppler Myocardial Performance Index, or the T index. And it says, T index is a useful, non-invasive Doppler-derived myocardial performance tool which can be used to assess aspects of systolic and diastolic function. Again, in the left ventricle, it's possible to obtain flow in systole and diastole in the same sample. The right ventricle, you can't do that with. You can't simultaneously record the flow across it and leaving it in the right ventricle. So in the right ventricle, you need to take 2 samples. You need to take one of blood coming across, and then very quickly, because you don't want heart rate to have changed or maybe to have moved to get out of the position, you want to quickly take a pulmonary flow also. Then you can measure ejection time by the pulmonary flow, and isovolumic contraction time and isovolumic relaxation time. The formula for T index is isovolumic contraction time plus isovolumic relaxation time divided by the ejection time. Here's our flow again. And now this is in the left ventricle because I'm obtaining both diastolic and systolic flow at the same time. So what you do is you're going to take a measurement of the ending of the flow in diastole to the time when the flow starts in systole. This is called your isovolumic contraction time. Then you're going to take a time from when systolic flow stopped to when diastolic flow started. That's the isovolumic relaxation time. So the formula is this plus this divided by your ejection time, and there's your middle number across there. And because we're involving both systole and diastole, we can get a global performance. So why do we care about that? Well, potential applications of the T index would be in the investigation again of IOGR fetuses, also of diabetic moms, fetuses with heart failure, including high drops, and fetuses with RH sensitization. The T index of LV myocardial performance should be considered by these authors a routine measurement of fetal well-being. So I think more and more we're going to be asked to do timing, and timing is very easily done with spectral Doppler. I do want to point out that the AIUM published guidelines this year in February for the performance of fetal echo. They've had guidelines in the past for OB and abdomen and other things, but they haven't had a specific guideline just for fetal echo. So to find that, you can go to AIUM.org.